My name is Till Barnighausen, and I will today give the lecture on pathways from social and economic experience to health and behavior outcomes, which I think is a very interesting topic and one where we in in-depth sites and health and demographic and surveillance sites often do research on. I'm an associate professor here at the Harvard School of Public Health. I have also over the past 8 years worked as first HIV epidemiologist and then senior epidemiologist in one of the health and demographic surveillance sites that form part of the in-depth network, which is the Africa Center for Health and Population Studies in rural KwaZulu-Natal in Matuba, which is a center affiliated with the University of KwaZulu-Natal and funded by the Wellcome Trust, where we have over the years, as in many health and demographic surveillance sites, collected in-depth, rich and detailed data on social, economic experience and, of course, behaviors and health outcomes. The basic course objectives here are that I think I want to convey a sense of what can be done and how we can think about pathways and causal analysis from social experience, economic experience to behaviors and outcomes. And of course, all this will be focused on using health and demographic surveillance data, and I will discuss many of the practical aspects of measuring and estimating these key independent variables that we are interested in exploring in their effect on health and behavioral outcomes, and give an overview of the state-of-the-art methods that are available in our toolbox to look at causal mechanisms, so that you have a conceptual understanding after this lecture of how these different methods relate to each other and how they can be used in practical application in health and demographic surveillance sites. And because I will be featuring several examples and ideas stemming from this one particular site that I've worked at for 8 years, here a quick picture of the Africa Center for Health and Demographic Surveillance, for Health and Population Studies demographic surveillance area. That is the gray shaded area that you see here in this graph. It's an area of about 430 square kilometers. The Africa Center is here in the middle of this area, and these red crosses indicate clinics, primary care clinics, where antiretroviral treatment and TB treatment and general primary care is delivered. The other red crosses here are part of the Klabisa sub-district in Umkhanyakude district in South Africa, health system where also ART and TB treatment as well as primary care is available. And this is an area that in total spans as a sub-district about twice the population that lives in this demographic surveillance area, which in total is about 90,000 individuals who we continuously survey here, as you do in many of the other health and demographic surveillance sites. And of course, we follow them up for the basic demographic characteristics: age, sex, birth, mortality, migration events. We follow up migrants when they're not in the demographic surveillance site, and as in many sites, distinguish between geographical belonging, that is joint living arrangements in households, which is a physical measurement, and then the social construct of belonging to a household as members of a household in this community without necessarily living together. These could be members, of course, who live and reside mainly outside the surveillance area, but still maintain social links with people in the surveillance area. And all households here are linked geographically into the surveillance area and to each other and to important structures such as clinics and schools, which I think is often important when we think about how to estimate the effects of social and economic factors on behavior and health outcomes. I want to start with a brief motivation and a few basic concepts in thinking about economic and social experiences in health and demographic surveillance sites, then go into some detail in measuring key health relevant economic and social experiences, and then give a detailed overview and detailed practical introduction to some of the methods that we might consider in a broader framework of experiments, quasi-experiments, and non-experiments. The motivation, of course, is we want often to generate basic understanding, just as the basic sciences are interested in relationships and causal relationships. Also in the social sciences, in demography, economics, we are interested in what causally affects our health, what causally affects behavior, and often we consider, when we are interested in basic understanding, these relatively distal factors that determine our health, our well-being, how we act, and these are, of course, often our economic circumstances and who and how we socially relate to others. We are often also concerned with notions of fairness or equity, normative notions how income should be distributed, and empirical notions in terms of equality and inequality, how income is distributed or wealth is distributed or educational opportunities are distributed across people. And it is often very informative to look at how income equality and inequality affect behavior and outcomes. Of course, we often have practical motivations, such as influencing policy, ensuring that policymakers know how to intervene. Of course, in economic policies, we are concerned with the final results that these cause when we, for instance, want to reduce poverty, what is one of the main thrusts of South African policymaking at this point in time. We are arguably very interested in how far policy reduction also improves longevity, people's quality of life, reduces hopefully morbidity, and improves health perceptions in people and quality of life. Of course, often we are interested in relationships that are causal between social and economic experiences and outcomes for advocacy, when we want to lobby or make a case that certain population groups should have improved educational opportunities. It does make sense here to argue that if we can add to the argument that health is affected by education, for instance. And finally, in analyzing causal relationships in as far as we can with existing data, we often have a forward-looking perspective that we want to intervene and also test interventions in rigorous intervention studies, and these analysis that we can do on the pathway to establishing causal pathways can be very useful in informing where and how we should intervene, given that we want to attain a certain outcome. There are many issues when we talk about social experiences and how they relate to health outcomes and behaviors. Certainly, we believe and we know, and it has been well established in many studies, that wealth affects health, which is the interest or the primary focus of this section. But we know there's also very likely the opposite pathway, that healthier people are wealthier. So there is a reverse causality running from health indicators to economic productivity, to school attainment. And this is both physical productivity, how hard and long I can work, but also how cognitively I will develop and how many educational opportunities I can actually make use of. A healthier child is likely to be more less absent in school and to be more active in school, to learn better, and thus as an adult to be more highly qualified and to be able to gain better income in labor markets. So there are many pathways running from health to wealth, and we need to keep that in mind. There's also the distinction between absolute and relative social and economic status, And this is a very long-ranging and one of the main debates in the social determinants of health, whether absolute deprivation and absolute levels of income matter, or not necessarily also, but potentially also and potentially jointly, the relative status of an individual in an income ranking or in a wealth ranking in their respective communities. And we can, of course, think about why absolute wealth and income matter, because when we have more wealth, we are able to buy the goods that can affect our health. When we have higher income, we have enough cash to buy a taxi, drive to the next health clinic when we need health services. We have more income to buy over-the-counter medication. So absolute income, for instance, clearly matters for accessing some of the healthcare we want to access. But of course, they matter differentially depending on the health system and how much the health system requires a co-payment from households and individual patients. The case for relative social and economic status is just as well argued. We can think about people feeling more insecure in societies that are more unequal. We might be more afraid of dropping in our economic ranking if the gradient of economic status is steeper. We might also feel more pressure and jealousy if we are in a higher gradient society. So there are plausible psychological mechanisms at work here. There are also physical mechanisms that in more unequal societies, the poor have a worse status than in more equal society, given an absolute level of income, because they might be receiving relatively less services. They might be the ones who are in the areas that are most dangerous to live in because they're polluted, and garbage is dumped in these areas. And we know, for instance, from slum settlements in favelas in Brazil, that people living on higher geographical altitudes are the wealthier people, and they are better off because the air is cleaner and there's less pollution, versus the people who live on the bottom of a slum, where there is more pollution and the air and general crowding conditions are worse. And that might be a pathway how relative social economic status affects our health and well-being. There are also micro perspective and macro perspectives, and I think at Health and Demographic Surveillance sites we're mostly concerned with micro perspective, with the individual and individuals in households and in their communities. But sometimes the macro perspective, the community perspectives come in very importantly, and of course some of the interventions that we can think about regarding improving economic well-being and social well-being are at the macro perspective, building a school, building a mechanism to access savings or to be able to save and access capital markets. Those interventions are often at the community level, and we cannot individually allocate them. And then there is the general view why we are interested in economic outcomes and them affecting health outcomes. That really what fundamentally in most policy we should be concerned about is not economic development, which is often used as an indicator of general development of countries when we measure, for instance, economic development in gradients of income and classify countries into high, middle, and low income countries. Arguably, income is not important in and of itself, but we care about it because it enables us to attain other goods, including long life. And this movement from economic development to human development, where other factors matter intrinsically rather than only instrumentally, such as income, I think is an important one, and it has been mainly brought forward by Amatera Sen and colleagues, who have argued that what we should strive for in economic policy and in policy in general is to give people capabilities, the opportunity of a full life, the opportunity to have the freedom to make choices such that we can determine our own lives and can reap the full benefits of our choices. And these opportunities are often not available to people who are economically deprived. So economic status and social status are instrumentally important. But given that these opportunities are available, we might argue we do not care so much about per capita income. We care mainly about health, we care about education because it increases our joy of life, but also instrumentally our ability to make choices and to decide who we want to be and how we want to live our lives. And that's, of course, a very broad notion, but I think it does provide a motivation why we are interested in the causal relationships from economic and social experiences to health, because we care about the economic circumstances, for one reason, as affecting our health, as affecting longevity and morbidity. And of course, without life, we have no opportunities. So it is intrinsically important to be healthy, of course, to be alive, and income, wealth, social capital affect life and health, morbidity and mortality. So one of the reasons why we care about the causal pathways from social and economic experiences to health is because of an intrinsic interest in human development and how we can achieve it. When we think about measurement in health and demographic surveillance side, I think many sites have an overlapping minimum set of measures. Very often we measure wealth, and sometimes we measure income and consumption, and I will talk about in some detail about these metrics as material measures, as measures that capture material resources. And then, of course, we often have education as an example of a metric of a non-material resource, and sometimes can derive measures of social capital because we have information about, for instance, group affiliations of people belonging to religious groups, social groups, and other ways to capture social capital. And I will talk about some examples how to measure social capital as another example of a non-material social and economic experience. And for each of these 5 different concepts, I will think through the definition of the concept, measurement in health and demographic surveillance sites, and measurement issues and partial solutions to them, and give a few examples. And then after this measurement session, I will talk about analytical approaches to estimating causal pathways from economic and social experiences to health outcomes. Income is the first major construct that I'm interested in here. Income is, of course, the what we have on an ongoing basis coming into our hands in order to spend it for consumption. And one view is income is the potential claim that we have on the economy, the potential claim on all the goods that are being produced in an economy. Income gives us an ability to obtain them. We might also think about income from a rights approach, that we have a right to a certain minimum income and thus a certain minimum claim on the economy. Consumption, on the other hand, is not this potential utilization or potential claim on the economy. It is the actual level of living. It is what we on a daily basis consume and determines thus how well we are physically. Of course, income gives me the opportunity to eat or to see a movie, but I make the choice how to consume and at what intensity level to consume. And that's an important distinction, of course. Consumption is also something that is smoothed over time because we plan, we make decisions to save, we make decisions to under or overspend relative to our income. And thinking about this relationship between income and consumption over a life cycle, I think can be very illuminative in being a little bit deeper in thinking about that relationship over an entire life cycle. The traditional life cycle hypothesis is that we underspend in youth, that we overspend in youth relative to our income, that we underspend relative to our income in the productive middle ages when we have a job and our income is high and we are economically productive, and earn an income in the labor market. And then again, we overspend relative to our income in old age. And one could hypothesize that given many assumptions, one would even out the consumption over time, given the fluctuating over age income. And in the end, there would be a net of zero. We would have saved in the Middle Ages and spent in the young and in the old ages. Of course, there are many immediately clear violations of this basic life cycle hypothesis. There are bequests. We get money from our parents who have saved over their lifetimes. This assumes a very information-rich environment where we know what we will earn over our lifetime, and also existing capital markets where we can save and take out money depending on in which life state we are. And of course, we know that we have to look at this in a multi-generational framework rather than in this simplistic way, but it reminds us how income and consumption are likely to some extent to be connected. In measuring income, which we are now very interested in because it captures the potential claim that we have on the economy, our consumption capabilities, if you will. We know from many studies, and including many health and demographic surveillance sites, that it is a relatively hard indicator to measure because it is a sensitive topic. We are afraid potentially of taxation. If taxation systems aren't very powerful or fear-causing, we might be afraid of informal income redistribution in societies where there's an expectation that if I have an income shock, if I earn unexpectedly more income, that then I should share into this windfall and give out to people who are related to me, my family members, my community members, and for that reason I might not want to share my income information with somebody trying to elicit it, such as a health and demographic surveillance site field worker. There may also be issues of social jealousy. We might want to avoid letting people know how much we earn because we are fearful. Others might be jealous and act in detrimental ways towards us because they feel we earn more than them and are thus more privileged than them. And of course, I might fear I could become a victim of a crime if it is known that I earn high amounts of income. And in assessing income, we face additional problems. There's not only the monetary income that is often quite clearly available in theory if people were willing to share it. There's also the much harder to assess in-kind income when people, especially in informal economic sectors, are paid or reap the payoffs of their labor in terms of in-kind payments, in terms of fruit, in terms of food, or in terms of access to school. So there may be ways of measuring in-kind income, but it is much harder to do. And finally, there are many sources, even of cash income. There's work, there's of course savings income and income from grants and pensions. For instance, at the Africa Center Health and Demographic Surveillance site, a very large proportion of income is via government grants that are given to people that meet certain criteria, such as old age or a health condition, or having taken on an orphan into your household or another child into your household. These grants constitute a very high proportion of cash incomes in this demographic surveillance site. Income also fluctuates very highly, especially in informal economies and economies often where HDSSs are located, where there is a seasonality, for instance, to production and income generation. We can, of course, in trying to elicit income, do a lot to do better. One is ensuring anonymity and data protection might take care of some of the concerns that we might become victims of crime or might need to give others part of our income. If it is really anonymous, we shouldn't be afraid of that. We can also ask in terms of broad income categories that avoid people giving us a precise number, so incomes between 10 and 50,000 Rand, for instance, and 50,000 and above, and 10 and below might be much less scary to people, for people to answer, than precise incomes such as 10, 20, 30, 40,000 rand. And we can make income concrete in asking the questions, and we can avoid potential issues that we sometimes face in population-based surveys where particular questions stop the interaction with the potential respondent because the respondent feels the questions have gone too far or so. So to avoid the issue, often income questions are placed last. So if income is taboo in your particular community and environment, it is of course a good idea to ask it last in a survey after respondents have given their responses to all the other questions. And I think many surveillance sites are doing that. We can also, of course, correct for non-response if it is there, and we can measure consumption as a proxy for income. And I think this is a good point to give the broad principles of non-response mechanisms that we encounter in all the data, but in particular also in economic and social experiences data that we measure in health and demographic surveillance site. And I just want to repeat this basic classification because it is so useful for thinking about what we can do in addressing non-response. There is missing completely at random, which is essentially when all the factors that determine whether someone gives you an income number or a wealth number or social capital data point are random versus that number, so that the selection does not affect in any way the average estimate of income, for instance. And that's shown here that the income or the missing data does not depend on all those factors that potentially influence it, whether they are observed or unobserved. Missing at random then is missingness when we control for all the factors that we can observe that affect the selection into giving, for instance, an income number, completely explain all the selection effects. So we can completely control for selection effects by using observable factors, for instance, in a regression equation or in a propensity score reweighting of answers. And after we have controlled for these observed variables in their effects on the outcome that we're interested in, missing is random. And then there is the most threatening form of missingness, missing not at random. And here we have to rely on more sophisticated selection models to account for missingness in this case. And the one that is easily available, I think, in Stata and many other computation environments is Heckman selection models, where we can use a variable that determines selection but does not independently determine the outcome of interest, for instance, income, to account for the selection effects in estimating average income or in estimating the causal impact of income on a health outcome. And here, just to link this categorization to the approaches that we can take once more, if missing is completely at random, we can do complete case analysis and we are fine. We get the correct estimate and we get the correct causal estimate of an impact on an outcome when we only use the information on those cases where we have full information. Missing at random, on the other hand, we need to account for selection effects, but accounting for them with regards to those selection factors that we have observed information on, such as sex and age and where people live, whether it's a rural or an urban area, accounts completely for the selection effects and generates an unbiased estimate after conditioning or accounting for these factors. And missing not at random requires Heckman-type selection models. Here is an example for income measurements from the World Bank Integrated Household Survey. The World Bank is probably the best place to go to if you're planning to elicit income information or want to improve the precision and detail of how you measure income. It is a highly detailed and sophisticated approach to measuring income and goes through, for instance, here a range of crops from which income can be obtained by selling these crops in a marketplace. In health and demographic surveillance sites, we sometimes do these types of questions, and sometimes we are much less detailed. But in a sense, the standard of measuring income are the World Bank surveys, and often HDSS sites have been inspired by the World Bank approaches to measuring social and economic outcomes. When we now switch to consumption, and I think many sites are measuring consumption to some extent in terms of asking respondents about household and individual expenditures, that's of course an important distinction, and we need to think about what we care about. Most commonly, household expenditures are asked about because the household head can well report on those and can report, for instance, also on spending for children who are not yet spending themselves, but expenditures are made on their behalf, for instance, for schooling access, and of course, those have health effects potentially that we're interested in. So here, of course, we are also, as for income, concerned about consumption with and without monetary outlay over the observation period. And again, we need to ask ourselves how in detail we want to elicit information on consumption, on expenditures. How many items do we want to ask about? How do we want to aggregate different items to come up with total expenditures for a household or an individual? And what are the costs in a survey of eliciting that information? Regarding the validity of the responses, there are of course all types of biases, but with expenditures, I think recall bias and telescoping bias are likely to be substantial. Recall bias, of course, we forget that we spent on a certain item, or we under or overestimate systematically relative to the time in the past when we spent on a certain item. Telescoping is a bias where we move the income estimate from a period that should not be included in our example into that period falsely. For instance, when we think that a health expenditure for a major health event, for instance a hospital stay, occurred in the past year, but actually it occurred longer than a year ago. So we are concerned in measuring consumption about a range of biases, but we have approaches, of course, to try to overcome them in asking the questions. For instance, telescoping can be avoided by asking for anchoring points in time to give people cognitive help in imagining when that time ended, for instance, over the past year, over the past 3 months or so. Often we are interested in total household expenditures, but in the elicitation of income, we ask about many detailed spendings, because that's the way people remember, right? It might be much harder to, I might have a much harder time to give you as a interviewer a total number of my spending per year, but if you ask me how much do you spend on groceries per month, I might have that number. So total household expenditures often need to be aggregated from these more individual levels. And when we think about household expenditures and individual expenditures, we often are interested on the effect on individuals and such, how much was expended on an individual, for instance, for healthcare seeking, for schooling, or total household expenditures. And here now we come into that issue when we measure, as we mostly do, expenditures at the household level. How do we distribute those expenditures across all the people in the HDSS households? And there are 2 basic practices. One is to weigh children at an adult equivalent, to weigh them differentially versus adults. And of course, because there are some goods that are shared amongst all the household members, if I as a household spend money on a television, then all household members can benefit from the television. The television consumption is not reduced by one person watching it. So we can come up with effective adult equivalents as rough proxies. And I think that's important to keep in mind, because often what we use as an explanatory variable is the per person expenditure. The per capita scale, of course, would which is shown here in the second column, give the same weight to all individuals in a household. There are two OECD scales, an old one and a new one, that give differentially weight to a second or a third or a later adult in the household, and the same for children, but a differential weight also between children and adults, weighing down children and weighing up in relative terms adults. And there is a square root scale where n is the number of household members, which gives us a different function than the per capita scale, of course, in estimating how much is spent on the individual in a household when what we have are household expenditures. And here are two examples, here are three examples from, again, World Bank surveys, the LSMS survey, living standard surveys that World Bank runs, which are again a gold standard, and you see how many items here asked for: 45 food items, 46 non-food items, for instance, in Vietnam, as items that we spend money on. And this is probably too detailed for most health and demographic surveillance sites. Here is an example from the Africa Center, where we had 18 items, and you see that we ask here for two types of estimates in a normal month. So we ask you as a respondent to average over time how much you're spending, or over the last 12 months, over a year. So here we ask you to give us a yearly estimate on such items as rent, water, electricity, fuel, cell phones, so many of the important expenditure items in households. A third measure, which has advantages over both income and expenditure assessment, is wealth. Wealth is, of course, a metric that captures long-term household socioeconomic status and economic experiences, and wealth is usually measured as net savings, as cumulatively income minus consumption over time. And we see households in particular states and can measure their past investments as a proxy for wealth. And that is often done and is a very robust measure, I think, of economic experience when we use household assets that we can directly observe, that we can, of course, ask about, and often it is not taboo to report on assets versus income, but often we can also independently, through observation, confirm whether a household has a chair, a table, livestock, cell phones, a television, and it's quick and easy to elicit assets information. One disadvantage about assets is when we use it as a proxy for differentiating people in their economic experiences and households in their economic experience is that certain assets have very different meaning regarding economic status in different areas, even within a country. For instance, owning livestock can increase your social status and your economic status in a rural setting, but it can mean lower economic status in an urban setting where having livestock would not be an indicator of belonging to the socially privileged classes, but an indicator of maybe recent in-migration from a rural setting. And when we measure wealth, of course, across all these many assets, as I've shown you as the example from the Africa Center, and they might include household water and electricity, and the quality of roofs and the quality of floors. We have a very large number of variables, and for interpretation, for not losing too many degrees of freedom, for instance, in regression analysis, and because we might run into multicollinearity issue if household assets availability in a household is very much related across assets. For these reasons, we might want to, which we often do, combine this information in a principal component analysis in a single metric or into a few metrics versus many, where we can, through an analysis identifying the joint variation across variables, extract information that is reduced. It's essentially a data reduction technique where we come up with a few components that capture a certain aspect of wealth, and that might be one component or it might be many components, and it is sometimes an art to see how many components we would want to meaningfully extract. The different components have often a meaning that we see when we look at which variables load particularly heavily on them, and we can distinguish what potentially a certain principal component might capture versus another principal component. There are many technical issues, and I don't need to go into them in detail, but we might want to rotate when we estimate components. We might also either constrain the components that we extract from the underlying many variables to be completely unrelated to each other, or on theoretical premises, we might often think that components should be related to each other. For instance, luxury wealth components and less luxury wealth components, and in this case we might allow the fact that they could be related to each other, and then we have a different component extracted. So these choices are important when applying principal component analysis, and I just wanted to hint at them because often in health and demographic surveillance sites principal component analysis is used, but the choices are implemented mechanically rather than thinking through the theoretical foundations for making particular choices for a particular analytical approach. And I think the latter is important. Hauer and Hargraves, Gabrish and Hutley have here validated wealth indices as also measuring consumption expenditure, and find that across many studies that have been conducted in the past, there is overall relatively good correspondence with wealth indices and consumption expenditures, so we can have hope in measuring wealth that we also capture consumption, which for many reasons we might, or for many analyses, we might care more deeply about than wealth. And here is an example from the Africa Center, the different assets that we elicit information on: telephones, cell phones, electric hot plates, kitchen sinks, car batteries for electricity, hot spades, garden forks. So it's a range of assets, and the joint information has proven to be very valuable for analysis for us. I will now talk about two non-material metrics, education and social capital, to also capture aspects of experiences, social and economic, that are not material, as are income and consumption and wealth. Education, of course, obviously is an important one, and we have in most health and demographic surveillance site information on. It is a component of human development, a very important component, because it determines how we are able to enjoy life, how we are able to invent things, discover new approaches to doing things, but also more pragmatically, our labor market incomes are very much related to the level of educational attainment that we have achieved. And the Millennium Development Goals, of course, push us to improve in developing countries the level of primary educational attainment, and to eliminate gender disparities in primary and secondary education. We also know that education affects our health, and those are the types of studies that we are interested in here, looking at the social determinants, economic determinants of health. But again, there's also a health to education pathway, which has less often been shown, but is very plausible, that a healthier child will develop better, will be more in school, and will be more active in school and benefit more from the same education than a sicker child. There are many issues in measuring education. Often what we have available minimally is a quantity measure, how many years of education has a person received, but that doesn't tell us about the quality of education. We might have long education but of low quality in one setting, and not as many years of education but at a high quality, and in the second setting actually the educational attainment is higher in terms of what it gives us for our lives, for our human development. We might also be measuring inputs in some settings and outputs in others. Inputs are years of schooling, grade repetition, school attendance, how many diplomas and certificates a person has obtained over a life course, even household expenditure on schools and supplies at the household level. And outputs are what arguably we care about: cognitive skills, complex or basic, general knowledge, specialized technical skills, but also something about our socialization and our values is important, because that's obtained partially through education. And here is the practical approach at the Africa Center, how we ask about education. So we ask about the highest educational grade a person has completed. We ask about full and part-time education, but as you can see, we do not have equality of education metric or measurement in the standard Africa Center Health and Demographic Surveillance questionnaires. Another non-material measure which is potentially very important and has spawned many studies, and many very interesting insights have come from these studies, is social capital. The idea that our social connectedness with others is a capital that we can draw on in order to obtain goals, life goals, and in that it is also a capability in sense where we have fellowship, goodwill, mutual sympathy, and social intercourse amongst groups and individuals, and those can be helpful in gaining opportunities to education, to starting a business, to basic choice of life. Socializing with others can be emotionally rewarding and can reduce depression prevalence and make us emotionally more stable. So there are many good things that can come from social capital, but there are also, of course, dangers in social capital and connectedness, depending on how communities and groups relate to each other. When thinking about social capital, there are many basic concepts, and I think there is a large discussion in the literature how we define and operationalize and measure social capital. It can be about relationships and reciprocity, trust and social norms. It can be about mutual acquaintance, and it can be pragmatically seen as something that facilitates collective action, community cooperation, and access to information, to skills, to things that instrumentally can help us in obtaining goals in life. There are a few basic distinctions that are important to keep in mind when thinking about social capital. Certainly it is, on the one hand, a concept that is not possible if there's only one person. So we always need the community. We need the group of people who relate to each other in some way. But we often ask about it in terms of an individual, and we often are concerned about the individual in obtaining, through social capital, health outcomes or change health behaviors because of social connectedness. So we have the distinction here that is important between the individual and the community concept of social capital. It can be seen as a do or a feel, as an instrumental or emotional concept of importance. So instrumentally, of course, we can use it to attain a goal. Emotionally, it might make us feel good. It might give us emotional satisfaction to be connected, to have many friends, and to be able to call on friends for help. Even if that is instrumentally important, it might also elevate us to a emotionally happier state. And then there is the distinction between bonding within groups as part of social capital, and social capital helping to bridge across groups which otherwise might be disconnected. Both might be extremely useful, both instrumentally and emotionally. And a similar concept is that of horizontal and vertical social capital, where horizontally it is within a level of society, and vertically, again, bridging social strata. Here's an example from Kim and Kawashi's paper, where they look at many different aspects of social capital. It can be social trust, it can be informal social interactions, formal social interactions, and group involvement, and religious group involvement, and group involvement for other particular purposes. So now I have gone through a range of approaches to measuring social and economic experiences in health and demographic surveillance sites. Often we have a rich set of variables and data on social and economic experiences, but all come with their own issues and their own problems. And sometimes for specific studies, we want to nest within an ongoing surveillance particular additional questions to gain in-depth insight in certain social and economic phenomena that are important for our health and for our behaviors leading to health. So in the next session, I want to talk about analytical approaches, how to establish causal links and causal pathways from social experience and economic experience to health-related behaviors and health outcomes.